Are we
Hello,
audible?
I'm Azeem Latib from Montefiore Medical Center in New York, and it's a real pleasure for me today to talk to you at the Gulf Interventional Society meeting on left main PCI techniques and strategies. These are my conflicts of interest. So I like starting with this slide. Here I'm showing you four left main bifurcations, and I think we can all agree that the anatomy is very different here, and to think that we could do all four of these bifurcations with a single strategy or a single technique is really incorrect. We need to adapt our technique and our approach to the anatomy and to the patient. And so one may say, in a case like this, maybe these two could be done provisionally, whereas the two on the left could be done with two stents. And then if we choose two stents, which strategy would we use to be able to treat these left main bifurcations? So I always try and plan my strategy beforehand. I take a number of factors into consideration, starting with the Medina classification. And so I want to know, is this a true or is this a non-true bifurcation? I then look at things like the plaque distribution, the calcification, the clinical presentation. But the most important factor is really what the side branch is like. So is this a side branch with extensive disease? Is it an important side branch for that patient? Is it a side branch with a large territory? And the reason is because the side branch really dictates our approach in deciding between provisional and two stents. Now remember, even with a provisional approach, you can still implant two stents, just we start provisionally and then we cross over to stent in the side branch. The only difference with a double stenting strategy is we start by stenting the side branch first and then do the main branch. And that really, all of that is dictated by the side branch and what we think, whether we think that side branch needs to be stented right at the beginning of the procedure or not. So for left main bifurcations, I still do provisional on most of my left main bifurcations. In over 80% of cases, I'm provisional. Uh, there are cases where I plan to do two stents, and those are cases that have a heavy calcified side branch, a severely angulated side branch with difficult recrossing, a side branch lesion length that's more than 10 to 20 millimeters, and if there's other significant disease close to the ostium of the side branch. Let's go through some clinical cases to show you. Here's a patient with a critical stenosis of left circumflex ostium with extremely calcified plaque. You can see how this sort of knuckle of calcium over here, probably a huge nodule right there. And you can see the extensive disease in the LAD. Now, in more than 90% of cases of left main cases I treat, the LAD is my main branch. There are some cases where I will consider the LAD is a side branch, but usually the LAD is the main branch and the circumflex is a side branch. So in a case like this with such diffuse calcium down this LAD, I clearly need some sort of calcium and lesion preparation. So in this case, I went with a rotablator, 1.5 burr. I burred down the LAD. Okay. You can see the burr making it all the way down. I then always after burr, I always go with non-compliant balloons. I started with 2.5 more distally and then 3.0 more proximally into the left main. Then I went with my first stent. I put in a long 2.75 by 38 millimeter stent, staying away from the ostium of the circumflex because I knew I needed two stents. And so by dealing with the LED, I dealt with the dissection, but I still left the ability for me to go down the side branch easily, which is in this case the circumflex, and treat the circumflex. In this case, I treated the circumflex with an angioscalp, got a pretty decent result with the angioscalp, and then went with my left main stent, trying to cover from the ostium across the bifurcation, overlapping with my previous stent. Here I chose a 3.5 by 22 millimeter stent. Um, and after implanting the stent, I then always pot first. So I went with a larger balloon, and then I recrossed to perform my final kissing inflation. So let's take you through the recrossing, which I think is very important. Now, the reason we always perform a pot is because we want to avoid this. Here's some images from the visible heart, and you see if you don't perform a pot, you have a proximal stent that's not well opposed, and so you can go under it. And this happens very commonly in the left main. Then you want to advance the guide wire, usually with a loop. I go all the way through the main branch stent, and then I come back to try and wire my side branch. And the technique for wiring is really the pullback techniques. We go distal, we then come slowly back, okay? And then as we come to the side branch, we wire. If you do it in this way, you're more likely to get through the distal strut, which will allow you, when you kiss, to have better scaffolding. Okay. Here you see what it looks like to have a distal cross. And it's really that pullback technique. The other thing, remember when stenting the left main, especially with the stent coming back to the ostium, is be careful not to deform the stent. We have much better stents now that are more resistant to deformation, but still, any stent can be deformed. So things to look at, if one of your wires is jailed, okay, be careful because that gel wire is going to pull you towards the stent. Also be careful of cannulating if you haven't performed the pot, pulling out your jailed wire or pulling out a partially deflated balloon. So here we then did our kissing balloon with 2 non-compliant balloons. I only use non-compliant balloons for my kissing. After I did my kissing, you get this kind of result. I then followed it with a pot. And this is hopefully the kind of result we're going to get with a well-opposed stent at the ostium of the left main. Here showing you the final result. And I think this is really an excellent result, considering that, we had a very calcified lesion here. You also see, I mentioned before, we did use a balloon pump in this case. I think there are lots of left mains where you can do either without mechanical support or even where a balloon pump may be okay. You don't need an impeller to do a left main. Sometimes, though, you start with provisional and then the side branch doesn't look great and you need to stent the side branch. I think for that, the tap is the best technique to cross over because really it's the least amount of steps and can get you the side branch stented in the shortest amount of time with a good result. So here's an example, another distal left main bifurcation, a patient with low ejection fraction. I placed a balloon pump here. This is what it looked like after a 1.5 rotablator, both towards the circumflex and towards the LAD. When you see such tight branches, I usually rotor the tightest branch first, and then I go to the other branch. Here then we stented the left main LAD and did a pot. This is what it looked like after the stent and pot. I think you'll all agree that this is a suboptimal result here for a very large, important side branch. So that's okay. We decided not to stent it up front, but it doesn't mean we can't cross over from provisional to stent it again when we see that the result is suboptimal. So here I did my tap. You can see the stent just there. And just sticking into the main branch and my main branch balloon ready. We inflate then the stent and the side branch. And here you see an example from the visible heart of how we do a pot. Pull the stent back just slightly so it's protruding. Inflate the stent. I then bring the balloon slightly back and do a high pressure inflation and then put both markers together of the balloons to do a kissing inflation. Here you see the final result, really an excellent angiographic result. Now, sometimes we really do have bifurcations that are more complex that require 2 stents. And the 3 techniques we tend to use is either culotte, de-stenting, or DK mini crush. And there are a number of questions that I look at to decide which one I'm going to use. And usually it's whether there's a discrepancy in the side branches, whether there's a dissection in both side branches, and I want to maintain flow, I may use one or the other. I think know one of these well, but I believe you need both of these techniques, particularly DK crush and culotte, if you're going to treat complex bifurcations. So here's a case where very diffuse disease, and we decided up front that because of the difficult wiring here, we're going to do 2 stents. And look at how challenging this circumflex bifurcation is. Again, we have a balloon pump, but look at this backwards angle here that we have to go down into getting into the circumflex. Right? So when you have to wire a circumflex unfavorable angle, my preference really is to use polymer jacket wires that I have a lot of control. I like Xeon Blue, I like Xeon Black, I also like Fielder FC. Sometimes I'll try Fielder XT, but be careful, you can dissect with a Fielder XT. And either you try and wire integrate, or you try and have an excessive extra curve and you pull back and wire. Another technique is also to use a dual lumen catheter like a Suzuki that can also help you with these difficult lesions. So here you can see how we did a pullback technique with an excessive curve with a polymer jacket wire. As you see, it drops into the side branch there. We then advance our wire. Here we did a DK crush, and here you see the final result after a DK crush. Really excellent result. I like DK crush, and this is a picture showing you why. This is what it looks like when you do a standard crush. This is what it looks like when you do a DK crush. After your first kiss, you have this wide open side branch in which you can stent into. And really, it gives you less stent deformation and less layers of stent near the carina in comparison to a standard crush. The last message I want to give you is about intracoronary imaging. I really think intracoronary imaging is essential, if not mandatory, in left main PCI, especially when you're doing bifurcations. Look at this complex left main that I stented. Really good result angiographically. However, when you go look at the IVUS, you see marked stent malapposition. Now, I would never have known this unless I actually did the IVUS. So after seeing it, we corrected it with high pressure balloon inflation, and you see really an excellent result. But remember, IVUS is not magical. It doesn't work just by putting it in and makes your stents better. You have to use the information that you get from IVUS to make yourself better. So you'll see in the Excel study that IVUS, because of IVUS, in over 50% of cases, the operator did something else. He post-dilated, used higher pressure, changed his strategy. So the last thing I want to say to you also about doing left main PCI is I think in every center there should be people who are more specialized in this. Because one of the things we've seen is that outcomes are really related to volume. Here's a study, looking at from England, looking at over 6,000 cases of left main PCI. And you look at some operators are only doing 3 or 4 cases a year. Okay, many operators, whereas there are only a few operators that are doing a lot. But if you look at outcomes, okay, and mortality, look how the mortality drops when you're doing more than 15 cases. There's a suddenly decrease in mortality. And even if we divide it by quartiles, you see that the operators who do the most left mains are the ones who have the best outcomes. So I don't believe you should be dabbling in left main. You really should find one, use an operator who has a lot of experience and gets a lot of experience every year doing these. So in final, my take-home messages is plan your strategy, try to keep it as simple as possible. It's a larger bifurcation, so there's less tolerance for errors. The provisional is a default approach with crossovers to tap stenting when needed. Sometimes we need to do double stenting. We see it more often with left main than non-left main. The choice of technique is based on your experience as well as the actual bifurcation morphology. But in the end, if you're going to do 2 stents, remember that the final results is what counts. And please use intracoronary imaging when you're doing left main bifurcations. It will give you better results. So thank you for listening. It's always a pleasure to talk to my colleagues in the Gulf. Bye-bye.
Okay, very good.